All right, welcome back to part 2 of our newborn class. So you guys would have finished watching the Khan Academy. I only had kind of that first video about just that fetal circulation and oxygenation, which I'm pretty sure you guys seen in term 4 as well. Following that one, I didn't assign it, is actually a really good video about what happens immediately after the baby's born. But we'll just kind of important to know about fetal circulation and how that blood moves around and what causes those changes after birth. And we will talk about that a little bit after too. All right, so in our in-person class or synchronous class when we meet at 11, I am going to ask you guys these questions. So I'm going to say, how is fetal circulation and oxygenation different from newborn and adult? And then we're going to touch base on, when we get together as a group, about what do we worry about the umbilical cord being around the fetus's neck. I know that seems a little, common sense might be concerned, but we're going to touch on that afterwards. So just recognizing that there is that foramen ovale and that ductus arteriosa that are there for a reason during fetal development and while that babe's in utero, but there's a lot of changes that happen when that babe transitions to extrauterine life. So there's kind of that first period of reactivity. So babe is just starting, just being born. They get that temperature change. They get those pressure changes as they go from intrauterine to extrauterine life. They take that first deep breath, which causes those pressure changes to happen. And then those shunts and those valves close off. They don't seal off, but they do close off with those pressure changes. And that's all triggered by temperature changes and changes in pressures due to those first few breaths. So that first period of reactivity as that babe transitions to extrauterine life lasts up to about 30 minutes after birth. And you can see some changes. Their heart rate really kind of picks up. Their respirations can be irregular, but that should settle in that first 30 minutes. And then they kind of get into a period of decreased responsiveness that can last for about an hour or so. And then they get into the second period of reactivity, around 2 to 8 hours of birth, where we can see them a little bit more active. So that's all kind of linked to our transition to extrauterine life, as well as just understanding these changes that happen in the circulatory system. And if we're not seeing these normal changes with, the heart rate kind of going up and the respirations being up, we know those are kind of normal in that first period of reactivity, but after 30 minutes, things should settle. And if they're not, or we're noticing they're just not pinking up, the breathing isn't slowing down, then we certainly have to start doing some deeper investigations in that. So right after born, so you're in the labor and delivery room, that babe is born, and what are those first initial assessments you're going to be doing? So you're looking to see, obviously we're going to do our APGAR scores. That's part of our initial assessment. We're doing that at 1 and 5 minutes of age, and then possibly at another 10 minutes of age if we need to. We're really watching that heart rate and those vital signs. We're looking at that tone, the color, how that babe's interacting. Certainly everybody wants to know, everybody seems like they're tense until that babe takes that first cry, right? Are they okay? Are they crying? And as soon as they cry, it seems like everybody kind of relaxes. So we're looking at, and then we're going right into that head to toe and that initial assessment with that newborn. So what else is happening right after birth in that first 2 hours? So what type of things are we doing? Well, we're making sure that our environment's not too hot, not too cold. We're monitoring to make sure that that babe's safe. So infection control measures, making sure that they're with their parents or skin to skin or with somebody so they're not getting too cold or they're not at a fall risk. And certainly we're watching to make sure that their vital signs are staying stable, that they're continuing to breathe well on their own, that their color remains pink, and that they're oxygenated, that they're getting air. So we're just and we're keeping a close eye on their temperature. So what happens is those first few breaths is we know that it's often that change of temperature, that cold, that often gets the babes to take that initial breath, right? And then they'll sometimes start crying, or we see those changes. So as soon as we get that first deep breath, that's when we start to see those pressure changes internally. So that first few breaths that pushes those fluids, starts to push those fluids out of the lungs. And now all of a sudden those lungs, which were such high pressure areas that had so much resistance in those lungs, now all of a sudden those lungs inflate just like this balloon, pushing all that fluid out. And now we start to see that blood flow as arterial, the foramen ovale and ductus arteriosa, they close, and now the blood starts shunting in those different paths and cycles. Okay? And as those transitions are taking place, we're really monitoring that, because this is a really high risk period. We want to make sure that all these things happen and that they happen well. So we're doing our APGAR scoring. So you're looking at the color, you're looking at the heart rate, you're looking at that reflex irritability, right? So, you know, if you kind of tickle their nose, or do they sneeze or grimace, okay? A muscle tone, respirations, are they active? So we're looking at all of these things, and we're hoping that we got a good lusty cry with good muscle tone and motion. You know, you stimulate them and they try and withdraw, or they grimace, or they don't want you to do that. They want a good strong heart rate of over 100 beats per minute, and we're looking at our color. Now, completely pink is sometimes hard to get. And this is where we get into some of our abnormal normals. Acrocyanotic, where the hands and the feet are a little bluer, that's pretty typical of our newborn, because it takes a while for that oxygenated blood now to start circulating through all the parts. It always goes core, central, essential places first, right? So we know our physiology is to shunt the bloods to our brain, to our organs, and our peripheral isn't as important. So we kind of see that in reverse with our newborns as they take those first few breaths and they start to oxygenate their systems with lungfuls of air. It takes a while to get to the periphery. But if they're all pale and blue, that's not good either. All right, so APGAR, this is what we're looking at. Okay, and we want an APGAR score ideally of 10, but anything over 7 just means that they're doing well. They've adjusted normally. Anything 4 to 6 is kind of moderate difficulty, bears watching. We're certainly going to repeat that APGAR score. And then 0 to 3, APGAR score of 0 to 3 is life-threatening. This is an infant in severe distress that needs resuscitation. And as you guys have been, as we're starting to go over with our neonatal resuscitation protocols, what is the number one intervention we can do in this immediate transition time with these newborns to help them transition? And that's airway. It's always about good ventilations, getting them oxygen, airway. So good positive pressure ventilations, big mask with the newborns. So what are our normal newborn vital signs? Well, we certainly want to see a heart rate. And here we say 110 to 160. You're going to see 100 to 160. Respirations 30 to 60. BPs we don't typically routinely do, but if we are doing blood pressures, and these are usually 4-limb blood pressures and they're ordered by the physician, these would be our normal values, but they're going to adjust as they get older. And then our temperature we want to see between 36.3 and 37.2. And we also want to make note of, are we doing that, we should be doing it axilla, but are we doing it as temporal, or how are we taking that temperature? So really important that you guys know these normals, because more importantly, if they're not within normals, we got to do something about it. Okay. So what do we expect to have happen? Well, our heart rate, we know it's going to fluctuate a bit. It's 110 to 160 is a pretty wide range, and those newborns tend to kind of flow through there. We don't want to hear any adventitious sounds or murmurs, right? We want that just that clear and crisp S1 and S2. Like I say, we don't routinely do BPs on newborns, but if there's any question about oxygenation, let's slap the SpO2 monitors on. Let's see how they're, let's check those vital signs again. Let's really check the tone and their color. And if there is any kind of concerns, then we're going to call the physician in, and then that's where we might order them to go to NICU for a 4-limb BP and maybe even an ECG. Okay. Respirations. We really want to look at our respirations. Newborns are periodic breathers. I don't know if you guys have ever really watched a newborn, but they kind of breathe. They're like, and then they cry and stuff too. So they're periodic breathers, and that's normal. But if they have these pauses for longer than 20 seconds, now we're apneic. Obviously, that's not normal. Immediately after birth, when they're taking those first few breaths in that first period of reactivity, you might still get that wet or crackles in the lungs that you might hear. But we shouldn't be seeing signs of respiratory distress. So anytime you're observing the newborn, the first sign of something going wrong with the newborn is usually going to show up in the respiratory system. So if you're noticing any signs of respiratory distress, so especially if they're tachypnic, they tend to kind of just breathe like, and it's very rhythmic, and it doesn't have that periodic kind of pauses and up and downs. If they're nasal flaring, they're grunting, or they're cyanotic and off color, or there's those tracheal tugs or retractions as so you all should be able to identify signs of respiratory distress, because a lot, like the tracheal tug, the indrawings, intercostal space retractions, indrawings, those are common signs of any age and population. All right. And then what are you going to do if your newborn is having trouble with their breathing, with their airway, if they're mucousy? So how are we going to help them clear that? So this is why we kind of touch base on our neonatal resuscitation with bag and mask and airway. But think about your infant CPR. So how are you going to help that newborn? And usually what we need to do is just stimulate. So we have that newborn, we kind of even if you're in that first immediate right after they're born, you get them up skin to skin on mom's abdomen and their chest, and you're drying and stimulating, and part of that is to help stimulate that respiratory system and to help clear that airway. If they are not clearing, then this is when we get into our neonatal resuscitation or our infant CPR, where we might do some back blows. We might, if we're in the hospital, we've got access to our resuscitation stations, we're going to bring them there. We've got to, ready to bag and mask and have some oxygen. So what newborns are at risk? Who are higher risk for being mucousy? So think about when a newborn may have more fluid collected in their lungs. Any ideas? Can you think about this? And I probably should have moved this slide to our synchronous session where we could kind of have some interaction and think about this. But our precipitous deliveries, so our babes that basically one push, mom shoots them out. They didn't get a lot of time for that squeezing and moving through the birth canal. It's kind of like the baby Heimlich maneuver with mom's pelvic floor. As that babe slowly moves through that birth canal, all that squeezing, contracting actually helps push a lot of those fluids out. And if you ever watch a delivery in slow motion, you can actually see as that babe comes out and comes up through the perineum, and you kind of bring them up to the mom's chest. Even that folding motion is kind of like the baby Heimlich, they kind of get some fluid out of there. So those are precipitous deliveries, those babes that didn't get a lot of that squeezing, that just shot out, they're at higher risk. Our C-section babes, the ones that come out through the surgical incision, how much squeezing did they get? So those typically tend to be our newborns that we see with a lot of mucus and who are a little bit higher risk for having problems breathing as they try to deal with that extra fluid. Another thing that we have to be really concerned about and really watch for with a newborn is temperature control. They are very immature systems and neurological systems, so we have to protect them so they're not losing too much heat. Okay, so and there's lots of ways they can lose heat. So think about evaporation. That's when you're wet. And as that water cools off of you, so when it was like plus 35, anybody go out to the pool or have a mister going, right? As that water evaporates off of our skin, that evaporation causes a cooling effect. So conduction, are we kind of on a surface that's pulling heat from us? Do we have convection or airflows or cold drafts that are pulling heat? Radiation, so is there a cold mass like in the winter beside the window when you feel the window and it's really, really cold, it's radiating cold? Do we want to put that newborn right beside that cold window? No, we don't. And we can get a newborn, we're always worried about cold stress and losing heat, but we can actually get a newborn too hot as well. So they have immature neurological systems. They are not able to maintain their own thermal regulation. So we have to be hyper aware of these environmental factors. So how do newborns help maintain or make their own heat? Well, they do have some innate metabolic processes called brown fat. So this is kind of a highly they can burn this brown fat very quickly right after they're delivered, anytime they've got stress, and that kind of gives them some extra heat and allows them to stay warm enough. Muscle activity, they can shiver, but newborns don't typically shiver. They'll tend to flex in to try and retain that heat. And then, of course, we get peripheral vasoconstriction. So if you see a newborn that's transitioned well, and then all of a sudden it looks like they got a little bit of mottling or that acrocyanosis again, so that their base of their fingernails are kind of cold or a little mottled again, they're maybe a little too cold. So let's get them skin to skin. Let's get them covered up. Let's do something to warm them up. So cold stress is a real concern with our newborn, guys. Anytime they're cold stressed or stressed, they're going to start to use up glucose stores. And not a lot of newborns are eating really, really well off the bat. They can rely on their brown fat. They do have some glycogen stores, but they start to increase their metabolism because they're cold stressed. They're going to run out of these reserves really, really quickly. So they're burning up their brown fat, their adipose tissues. This is their increase in metabolism kicks off burning this up, but they've only got so much. Okay? Oops. And then as they're cold stressed and they're burning up the brown fat and they're increasing the metabolism, they need more oxygen. So this can lead to hypoxia and potential respiratory distress, and it can lead to hypoglycemia. So this is really critical that we are managing the temperature on our newborns, and that's why we do frequent temperature checks, especially in that first 24 hours. So as I said, newborn gets cold, all of a sudden they start to increase their metabolism, which increase their oxygen consumption. And then if this goes on, we can get a metabolic acidosis going on. We can also get a hypoglycemia going on. And these long-term stressors can potentially lead to some poor outcomes. All right, one of the other things we're going to look at is let's look at infant size. So part of our data collection, our assessment with the newborn, is weighing them and seeing where they graph on the graphs for gestational age. We want them to be appropriate for gestational age. This should be a little bit of review. We went over this with our newborn assessment lab in our skill review day and in that first newborn assessment guide from September 8th. You would have had this the graph where you could look at where are they. Are they between the 10th and the 90th percentile, which would be appropriate for gestational age, or are they below the 10th, which is small for gestational age, or are they above the 90th? That's large for gestational age. So you've got a 2,750 gram infant. What do you think? Are they appropriate for gestational age, small for gestational age, or large for gestational age? Well, We don't know that for sure without having the graph to graph that on, but that's a pretty small infant. So they're small for gestational age, especially if they're term. Obviously, if they weren't term and they were 30 weeks, they might actually be large for gestational age. But we got to get it on the graph, and we have to see where they are on that graph. So it's weeks of age plus weight allows us to determine where they are in the percentiles. So small for gestational age newborns. We got to start thinking with our nursing critical thinking cap. We got to start saying, why is this infant small for gestational age? What were some of the underlying conditions or factors that were going on that might have contributed to that? So was there problems with growth and development because of blood flow? So anything that can impact blood flow in the placenta, that can cause small for gestational age. Is there some kind of a underlying birth defect that doesn't allow them to optimal growth and development? Were they twin or triplet or quadruplets? Was there anything going on with mom that would impact blood flow to the placenta or the quality of nutrients in the blood and how it's crossing over from the placenta to the fetus? So, all of these things can certainly have impact and are a lot of our common reasons for small for gestational age newborns. All right. So what are we going to do if so these are some of the common things that we'll see with the newborn. So just that problem transitioning there where they're not breathing well. Is it maternal medications? Did she have a lot of pain meds during labor that the side effects is depressed respiratory drive? Is there a lot of mucus? Is there something blocking that airway? So certainly if there's any problems with the breathing, we have to look at our resuscitation and managing our airway as soon as possible. Hypoglycemia, very common, so we got to be thinking about, is there some reason why this newborn's burning up all the reserves? But we want to keep them warm. We want to monitor if they are showing signs of hypoglycemia. So, are they a little jittery, right? And we've got these newborns and they're kind of shaky and they're jittery. We want to make sure that we're doing their blood glucose. And we want to look at heat loss. So, are they too hot? Are they too cold? Most likely they're too cold. We got to bring that temperature up, get them skin to skin, try and get some food into them. So, what about if they're large for gestational age? So our LGA babes, well, what is often causing that? Almost always maternal diabetes, or either diagnosed or undiagnosed. So you think about maternal diabetes. We've got our mom. If she's really, really well controlled with her diabetes and it's kept within a very narrow range, you're most likely not going to see some of these effects, okay? But if it's poorly controlled, and there's a lot of reasons why it might be poorly controlled, then you're going to see these babes that have had a lot of extra carbohydrates, calories, they've had, access to a lot of glucose, and they've put on some pretty good weight while they're in utero. And maternal diabetes, again, is one of those conditions that's considered a teratogen. So that can lead to birth defects, and they can be more likely to be post-term. So when you've got a large for gestational age babe, think about maternal diabetes or undiagnosed maternal diabetes. Okay, so you thought about it. All right. But what does that actually mean? Well, we have to understand the physiology behind maternal diabetes and the impact on the developing fetus. So if mom has poorly controlled diabetes and she's always running hyperglycemic, then that means that babe, that glucose transfers very well across the placenta. So that means that babe has access to a lot of extra glucose. But what's the babe's physiology doing? The babe should have normal physiology to deal with glucose. If they're not type 1 diabetic or they're not a type 2 diabetic yet, which they shouldn't be. It's very, very, very rare. So they actually have the islets of Langerhans and a pancreas that is working well. So what are they doing about that extra glucose? Well, they're packing on pounds. but they're also kicking out a lot of insulin into their system to deal with it, and then of course store it. So these babes have a very, very high insulin set point. So as soon as they're born and they're no longer getting all that glucose through the blood supply, through the placenta, they can crash because their set point for how much insulin they set up is really high to deal with that high glucose. Now that high glucose isn't there, but they've still got high insulin levels. So some of these babes manage to transition well, and their insulin set point, stabilizes very quickly, but other babes don't, and they will crash. So we really have to monitor them for signs and symptoms of hypoglycemia, as well as this is newborns that we will do blood glucose monitoring on to monitor the blood sugars for. So yeah, if mom's got maternal diabetes, watch for these LGA babes. So even if she has not been diagnosed with maternal diabetes, but you've got an LGA baby, you'll really want to be watching for hypoglycemia. This can be critical. All right. And what else? What other complications can we have with the LGA babes? Well, there's less room to get out. So we have to be thinking about birth trauma. Watching for the fractured clavicle. Do they have bruising? Were they stuck for a while? Soft tissue injuries, right? Any kind of movement from changes in movement because of pinched nerves. So they have Erb's palsy, where part of the face is kind of froze. Thinking about the hypoglycemia, like I said. And then, because we know maternal diabetes can be a teratogen, watching for any kind of congenital problem. So really good assessments. All right. And then we're going to look at the head. So the newborn of the head. Or the newborn's head. So this is part of our head-to-toe assessment, but with the newborn, we're really paying very close attention to it because it's very malleable and it can mold. And you look at all the skull plates on the newborn, they can shift and adjust and change, and they need to, so that they can shape and get narrower so they can be born. But we do want to watch and make sure that that there isn't any issues with that. So we're checking these suture lines. Right, so our cranial suture line, our sagittal suture line, this is our cranial, our anterior, and then our posterior, or lambdoidal. And then we're checking for any kind of head trauma as well with that newborn. All right, so as we talk about head trauma, we're going to segue into this video. So if you guys want to stop here, and then we're going to watch this video, and then we will be back.